Hello everyone, myself Dr. Prashant, and today we are going to discuss about osteoporosis. So osteoporosis is a systemic skeletal disorder which is defined by reduced bone mineral density and distorted bone microarchitecture, where the susceptibility of a bone for fragility fractures is increased. On DEXA scan, how do we define osteoporosis? Is T-score less than minus 2.5. This is osteoporosis. And when T-score is in between minus 1.02 minus 2.5, this is defined as osteopenia. In today's lecture, we are going to discuss about different drug options which are available for the management of osteoporosis, when to start these agents, when to switch these agents, when to stop these agents, when to order DEXA scan, how to interpret DEXA scan, and why should we treat osteoporosis at all. We are going to discuss about all these facts in today's lecture. So this definition we have already discussed. Now we are going to discuss about various drug options which are available to us for the management of osteoporosis. So there are broadly two categories of the drug. One is anabolic drug, which is bone forming agent, and another is anti-resorptive, a drug which prevents resorption of bone, ultimately increasing bone mineral density. So under the first category, that is anabolic agent, we have parathyroid hormone analog, that is teriparatide, and a newer drug, abaloparatide. Under the category of anti-resorptive, we have selective estrogen receptor modulators, we have bisphosphonates, we have calcitonin, and we have denosumab, which is a newer drug. And there is one more category, a drug which acts by both the mechanism of anabolic as well as anti-resorptive, that is romosozumab. This is also a newer category drug. Now we are going to discuss each agent briefly. So teriparatide is an agent which is analog of PTH hormone. This is given subcutaneously, daily injections. And what is the dose? 20 mcg subcutaneously. And this is a bone forming agent. So this is the mechanism of action we have already discussed, analog of PTH hormone. One thing we should be knowing about teriparatide is that maximum teriparatide can be given to a patient for 2 years only. After this, chances of development of osteosarcoma increases. That's why we should never give it more than 2 years. But in today's era, with recent literature and newer studies, we are coming to the fact that in high-risk patients, we can give it for maximum 3 years. And one more thing that we should know about the drug is that once the drug is discontinued, its effect goes off rapidly. So we need to give replacement. And what does it mean? How does it go rapidly? If I draw a graph like this, where this is the duration for which the drug is given, and this is the rise in the BMD. So if I have started the drug over this region, so with the continued effect of the drug, the BMD was increasing like this. So if at this point of the time, if I discontinue the drug, so the effect will come down rapidly with the discontinuation of the drug, and it would come to the baseline within few months only. So this is how the effect goes away very rapidly. So during this period, we cannot leave the patient alone, and we need to give a replacement, maybe bisphosphonate therapy. So this is one thing we should be knowing about teriparatide. Abaloparatide we have already discussed. This is a congener of teriparatide only. It acts by two mechanisms, by PTH related peptide as well as PTH related mechanism. Most of the trials have shown that both teriparatide and abaloparatide have got similar efficacy, but active trial shows that abaloparatide is better than teriparatide. This is one trial which shows better efficacy of abaloparatide compared to teriparatide. Now coming to the bisphosphonates, we have already discussed that they are anti-resorptive agent which are present in both IV and oral forms. And there are two kinds of bisphosphonates. One is nitrogen containing, another is non-nitrogen containing. What is the mechanism of action and what all drugs are included in these categories, we will be discussing in this slide shortly. So let's just erase it. Now coming to their discussion. Nitrogen containing bisphosphonates, they actually acts by inhibiting farnesyl pyrophosphate synthase, an enzyme which is required for the osteoclast for their activity. This diagram will be showing us how the drug acts. This is HMG CoA reductase pathway, in which this enzyme is inhibiting FPPS enzyme. So ultimately cholesterol will not be formed. So a mature cell membrane will not form. And what does it lead to? Obviously this cell will lead to apoptosis. So these osteoclasts will ultimately go towards apoptosis. So what all drugs are included in this bisphosphonate, which is nitrogen containing category, are alendronate, ibadronate, trisronate and zoledronate. Among these drugs, most commonly we are using alendronate, that is oral formulation, and IV formulation, that is most commonly used is zoledronate. And the most efficacious drug among these is zoledronate, which is IV. Now coming to the next one, non-nitrogen containing agents, they actually act by, they are metabolized into toxic analogs of ATP in the cell. And what these toxic analogs are going to do to the cell, they are going to lead to the apoptosis of the osteoclast. So tildronate, chlordronate and atidronate are the non-nitrogen containing agents in bisphosphonate categories. Mostly they are not readily available in India, so not most commonly used. Alendronate and zoledronate are the most commonly used in clinical practice. So this diagram shows a difference of mechanism of the two drugs, nitrogen and non-nitrogen containing bisphosphonates. This is nitrogen containing bisphosphonate, which inhibits this enzyme, FPPS enzyme. Ultimately, defective cell membrane will form and it will lead to the apoptosis of the cell. And non-nitrogen containing agents, they are metabolized into the toxic metabolites of ATP. Ultimately, they will accumulate in the cell and leading to the apoptosis of the cell. This is how these two agents will act in a cell. Now, we should be discussing a few facts about the bisphosphonates. One fact is that, unlike teriparatide, where the effect of the drug was going away rapidly after discontinuation, here residual effect is present in bisphosphonates. What does it mean? Let me draw a graph. This is the rise in the BMD and here duration. So if I have started the bisphosphonate drug over this region, with some time the BMD of the patient is going to rise. If I discontinue the drug at this point of time, the BMD will not rise very rapidly, but it will stay elevated for a period of time, maybe for 1 to 3 years. That is different for different bisphosphonate. Okay, and after this duration, it will again start coming down. So this is the basis for drug holiday in bisphosphonate drugs. During this period, even if we don't give bisphosphonates, patient will have elevated BMD and the risk of fragility fracture will still be low, even if patient is not taking any drug. Okay, so this is what we have discussed. And maximum duration for which we can give bisphosphonates is something we should discuss. Is generally they are given for 3 to 5 years. Oral drugs for 5 years, IV for 3 years, but maximum you can extend it up to 10 years maximum for high risk patients. What high risk patients are, we will be discussing in subsequent slides. And for IV drugs, maximum you can give it up till 6 years for high risk again. Okay, now coming to the next slide, drug holiday we have already discussed. For bisphosphonates, once we have given the drug for 3 to 5 years, we can take drug holiday of up to 2 to 3 years depending upon which agent we are using. For zoledronate, up to 3 years of drug holiday can be taken. For alendronate, 1 to 2 years of drug holiday can be taken. So coming to the next slide, denosumab. Denosumab is a monoclonal antibody to the rank ligand. This is also anti-resorptive drug, monoclonal antibody to rank ligand. And this is also given subcutaneously, 6 monthly injection and sometimes yearly also, 60 mcg. This is the dose of the drug. Okay, so this diagram is showing how does it act. So this is very well shown in this diagram that osteoblasts do produce what we say rank ligand, and denosumab comes and binds to these rank ligands. Ultimately, it will prevent maturation of osteoclast. So no bone resorption will happen. One thing we should be knowing about one thing we should be knowing about denosumab is that it does show rebound phenomena. What rebound phenomena is, if I again draw this graph where BMD is shown on this side and duration is shown over this side, I started denosumab in this patient and BMD started rising like this. Now I discontinued the drug over this period. After the discontinuation of the denosumab, the BMD starts falling down and it goes even lower than the previous baseline BMD. So the risk of fragility fractures increases even further than it was before starting the drug, once the drug is discontinued. So this is what we call rebound phenomena. This is found in denosumab. Romosozumab, we have already discussed. It acts by dual action. It increases bone formation as well as it reduces bone resorption. This is given in monthly injection forms, and this is the mechanism of action of romosozumab. This is inhibitor of sclerostin in WNT pathway. So when should we consider anabolic agents over antiresorptives? There are two conditions. One is whenever patient presents to us with fragility fracture. The presentation is of fragility fracture, then always consider catabolic over antiresorptive agent. Second is when the T-score is very low, that is less than -3.5. In these two conditions, we should always start for anabolics over antiresorptives. Okay. So coming to the contraindications of these drugs, there are certain conditions when we avoid certain drugs. What these are? For teriparatide, whenever a patient is having history of renal failure, don't give it. And whenever a patient is having history of primary hyperparathyroidism, don't give it. Why? Because teriparatide is known for hypercalcemia. And if the patient is already having hyperparathyroidism, the chances of hypercalcemia will be too high. So don't give it. Now coming to the bisphosphonates. What are the side effects? One is gastric upset. So don't give it when patient have history of esophageal erosions. And second is same, renal impairment. For patients with CKD, AKI, don't give it. So if a patient with renal impairment comes to us, what can we give? In that case, neither bisphosphonates nor teriparatide can be given. Then we can go for denosumab. This is the only drug which is left in these patients. Okay. So looking at this radiograph, we will be discussing a short case. This was a 70-year-old lady who had right-sided neck femur fracture, and for which we done bipolar hemiarthroplasty, mobilized the patient. She was happy and we discharged her. After 4 to 5 months, she came back with the history of recurrent fall. Now this time she have left-sided neck of femur fracture. In this patient, as a surgeon, we have done wonderful job. We replaced the hip, mobilized the patient. She was happy. Everything was fine. But as a clinician, we have failed her. As a clinician, we did not treat the patient in holistic way. We did not start anti-osteoporotic medication. And because of that, after 4 to 5 months only, after recurrent fall, her BMD was not good enough to sustain that fracture, to cope with that fracture. And she developed contralateral sided neck femur fracture, and that should not happen. So this is what I wanted to teach through this video, that anti-osteoporotic medication should always be started in these elderly patients to reduce chances of fragility fractures. So this is what we have discussed where we have failed. Now coming to the presentation of osteoporosis. Osteoporosis doesn't show clinical symptoms. Most of the times patient presents with fragility fractures. That is the only presentation of these conditions. One more presentation that is detected on DEXA scan is T-score less than -2.5. So these are the clinical presentations of osteoporosis. Coming to the next slide. What is DEXA scan? Now we will be shortly discussing about DEXA scan. What is the full form of DEXA scan? Dual energy X-ray absorptiometry. What does absorptiometry mean? In DEXA scan, we are calculating BMD of the patient depending upon differential absorption of X-ray by skeletal system of patient. How? We will be discussing that. Supposingly, in this diagram, this is the bone of the patient, and this is the incidental X-ray. I is the incidental X-ray, and this is the outward ray after absorption from the body, depicted by O. So difference between I and O is the absorbed ray, and depending upon this absorption only, DEXA machine calculates BMD in this patient. Now one question that arises in our mind is that why are we taking dual rays, dual energy X-rays? Because if this is the body of the patient, inside that body, bone lies over here. Outside the bone, we can have soft tissue of different density in different patients. Supposingly a patient who is lean and another patient who is very obese. In these two categories, the absorption of the rays by soft tissue can give spurious results about the BMD. To counteract that effect, we do bombard these patients with X-rays of two different energies, so that the differential absorption between the two will help us in calculating true BMD, and the effect because of the soft tissue will be eliminated. So this is how a normal BMD looks like. In BMD we have T scores and Z scores. Generally we look at T scores in elderly patient and we look at the Z scores for young patients only. So this is how a normal BMD and normal DEXA scan looks like. Coming to the FRAX score, FRAX is a fracture risk assessment tool, and this is a questionnaire actually in which we have a set of different questions. Firstly, we fill the age of the patient, sex, weight and height, after which we ask the questions regarding the previous fractures, that is fragility fracture, history of fragility fracture in parents, smoking, glucocorticoids, history of inflammatory arthritis, then any secondary osteoporosis or history of alcohol intake, and BMD at the femoral neck. Depending upon all these parameters, we calculate the risk of fragility fracture at hip and other sites. If at the hip this is more than 3% and at other sites this is more than 20%, then FRAX score is suggestive of very high risk and we should start anti-osteoporotic medications. When do we order DEXA scan for a patient? So according to International Society for Clinical Densitometry, that is ISC, for all women more than 65 and all men more than 70, we do prescribe DEXA scan. And for all the postmenopausal women and all men or women who are more than 50 but with high risk factors. What all are the high risk factors? Patient on glucocorticoids, patient having inflammatory arthritis. These are the patients who are at high risk. In all these patients, we should screen them by DEXA scan. And any patient where we are going to start medication for osteoporosis, in that case also we need to get DEXA scan as a baseline. And for all the patients who are on anti-osteoporotic medication, for them also for monitoring, we can get DEXA scan. Okay. So when to start the treatment? Whenever a patient does have fragility fracture, whenever the T score is less than -2.5, that is the determinant of osteoporosis. And whenever a patient, even if the T score is not that low, not less than -2.5, but FRAX score at hip is more than 3% or other sites is more than 20%, that we have already discussed, then we have to start the treatment. And this slide we will be discussing in detail. Fracture widgets fracture. What does it mean? Whenever a patient does have fragility fracture, even if the BMD is fine, in that patient, the chances of future fragility fracture will be very high. Why is it so? Because bone is not just BMD. Bone is a living structure where it does have microarchitecture, it does have dynamic bone reactions, multiple things are happening at microcellular level. And even if the BMD is normal, the bone might not be healthy. So if ever a patient is having fragility fracture, that does mean that the bone is not healthy. And if patient develops fragility fracture, definitely the chances of future fragility fracture will be very high, even if the BMD is high. So although BMD is a predictor of fractures in most of the patients, sometimes BMD is not that accurate. So always fracture in a patient, fragility fracture in a patient will be a predictor of future fragility fracture better than a BMD. Now we will be discussing about various trials regarding the efficacy of different drugs which are given in osteoporosis. The first one is ARCH trial. ARCH trial is regarding the efficacy of romosozumab. So ARCH trial was performed in postmenopausal women who were at high risk. What they have done in ARCH trial is, so this is control group, this is case group. In control, they have given alendronate for 1 year, followed by alendronate for 2 more years. But in cases, in study group, they have given romosozumab for 1 year, followed by alendronate for 2 years. And when they compared these two groups, romosozumab followed by alendronate was a better combination than alendronate only. So coming to the frame trial, the same study in postmenopausal women, but this time the postmenopausal women were not high risk. In this case, they have cases over here and controls over here. In control, they have given placebo subcutaneously for 1 year, followed by they have given denosozumab for 1 more year. But in cases, they have given romosozumab for 1 year, followed by denosozumab for 1 year. And definitely, the results were romosozumab followed by denosozumab was better than placebo followed by denosozumab. Now, freedom trial is all about the efficacy of denosumab. And in this trial, they came to the conclusion that whenever a patient receives denosumab, the effects are better and it reduces the risk of fragility fractures. And now we will be discussing about this narrative review, which was recently published by Dr. Manju Chandran. And this is very helpful regarding the rationale of sequential and combination therapy in osteoporosis. What these sequential and combination therapies are, we will discuss them by this case scenario. So a 72-year-old lady who had fall and multiple fractures. We have done DEXA for this patient and we came to the conclusion that this patient have T-score of minus 3.2, definitely osteoporotic. So we started her on alendronate, that is anti-resorptive agent. At the age of 74, after 2 years, she comes back to us and again she has sustained a fall this time and now she is presenting with left-sided neck femur fracture. Definitely her BMD was not well good. BMD was not increasing with alendronate. That is the reason this time after a simple fall, she has sustained this fractured neck femur. So what should we do? Should we change the drug? Should we combine it with some other agent? So what is the rationale? Here comes the concept of sequential and combination therapy. So we will be discussing about the sequential and combination therapy in subsequent slides. So what sequential therapy is? Supposingly a patient was on anti-resorptive agent and now because of side effects or loss of increase in the BMD, the patient requires change of the drug. We can change it to anabolic agents. Can we do it? Is it rational? We will be discussing. In second case, supposingly a patient is on anabolic agents. Now, it requires change for the listed reasons which we have already discussed. Now, can we change it to anti-resorptive agents? The rationale for this change we will be discussing. And the third one is patient is on anti-resorptive agent and can we change it to another anti-resorptive? We will be discussing these in detail. So this slide shows that whenever a patient is on anti-resorptive agent and if we change it by anabolic agents, supposingly patient is on raloxifene and we change it to teriparatide, patient is on bisphosphonate, we change it to teriparatide, patient is on denosumab and we change it to teriparatide. Is it rational? This study says that it is not rational, it is not recommended, because if we do so, there is no benefit and sometimes even there is loss of BMD. Either BMD will not increase or sometimes BMD may even reduce also. So, after giving any anti-resorptive agent, we should always avoid giving anabolic agents. For example, if a patient have received zoledronate in past or alendronate, can we give teriparatide now? This study says no, this should not be given. Now coming to the next slide. This slide says we have given anabolic agent to the patient like teriparatide. This is shown over here. Romosozumab, this is shown over here. Can we give anti-resorptive after that like bisphosphonates, denosumab or IV bisphosphonate like zoledronate? This shows that mostly there is benefit, mostly. So after giving anabolics, if we give anti-resorptives, yes, green signal for this. It can be given. Green. Go for it. There's always improvement in BMD whenever we are giving anti-resorptive after anabolics. Now coming to the next slide. If we have given anti-resorptives to the patient, like patient was on alendronate, can we switch it to some other anti-resorptive? Study says yes, you can do, but always change it to a stronger anti-resorptive. Like patient was on alendronate, change it to zolendronate, not vice versa. Patient on zolendronate, change on denosumab. This is what the study says. And obviously, changing from anti-resorptive to a stronger anti-resorptive is always more ideal than switching to anabolic. So if patient is on alendronate and if you want to change the drug, always go to the zolendronate, not from alendronate to the teriparatide. This combination, alendronate to teriparatide, is not recommended, but this one combination is recommended. Coming to the combination therapy, the patient was on teriparatide and again having neck femur fracture. So what should we do now? We can combine it with some other drugs. This study says that teriparatide can be combined with zoledronic acid, that is IV, and it can also be combined with denosumab, but never with oral counterparts. Okay, so this slide is showing that whenever a patient is receiving bisphosphonate already, if we combine it bisphosphonate with teriparatide, the effect is same, bisphosphonate or teriparatide alone. This is same. But whenever IV bisphosphonate is combined with teriparatide, effect will be better than teriparatide alone or IV bisphosphonate alone. And similarly, denosumab with teriparatide, effect is better than denosumab alone or teriparatide alone. So the summary of sequential and combination therapies is that after anabolic, anti-resorptives, go for it, can be given. After anti-resorptives, anabolic, no, don't go for it. Patient on anti-resorptives, 2 anti-resorptives, yes, you can go for it, but with stronger anti-resorptives. Teriparatide with IV zoledronate and teriparatide with denosumab can be given, but teriparatide with oral bisphosphonates like alendronate should not be given. This is the summary of this narrative review that we should keep in our mind. Along with these medications, we should always supplement the patient with calcium and vitamin. These are the doses for preventive and treatment measures. Calcium for prevention 500, for treatment 1200 mg daily, and vitamin D for prevention 400, and vitamin D for treatment is 800 daily doses. And lifestyle modification obviously needed. Strength training, posture training, fall prevention should be told to the patient. 30-minute moderate intensity workout and post fracture rehabilitation is required. And there are certain examples that we should be discussing about the lecture. A 65-year-old female who had right neck femur fracture at home. Management plan, obviously we will go for surgical management, bipolar hemiarthroplasty for this patient, followed by anti-osteoporotic medication. Which one? Anti-resorptive or anabolic? Which one should we give? Since the patient is having fragility fracture, ideally we should go for anabolic like teriparatide. Coming to the next example, a 60-year-old female patient on alendronate since 1 year already, now coming with hip fracture. What should we do? Can we give teriparatide after alendronate? Go to the narrative review. After anti-resorptive, can we go for anabolic? No, we cannot go. So what option do we have? Either we can start with either IV zoledronic acid or denosumab. This is what we can do for this patient. Okay, 62-year-old female patient on teriparatide since 6 months. Now she is having vertebral fracture. What should we do? Now comes the concept of combination therapy. Teriparatide with zoledronic acid we can give, or teriparatide with denosumab we can give. Okay, coming to the next. A 65-year male with hip fracture and T-score of -4.5, very low in this patient, and having fragility fracture already. He is very high risk patient. What should we do after surgery? Surgery we have done. What anti-osteoporotic medication to give? Should we give this alendronate? No, not at all. Should we give teriparatide? Yes, can be given, but other options are also available. Alendronate with teriparatide? No, a big no. We have already seen in combination therapy. This combination is never given to the patient. Teriparatide with denosumab, this is a good combination, and for this high-risk patient, I feel this is the best option. We should be giving combination therapy to this patient because he's already very high risk. 70-year-old male with hip fracture, for which surgical management done, and he is started on anti-osteoporotic medication. We have given teriparatide for 6 months. How to proceed? We can give teriparatide for maximum of 2 years, after which we have to switch it to which agent? Yes, anti-resorptives we can give. Before 2 years also we can switch. If the patient is not high risk, if there is stable BMD, then we can continue this teriparatide for 6 months to 1 year only. Then also we can switch it to anti-resorptives like alendronate or zolendronate also. So this is all I wanted to discuss about osteoporosis and its management.